Retinal detachment. As soon as I hear this name, I think it is very easy. Yes? What do we mean by retinal detachment? Detachment of the retina. As simple as that. Yes or no? Yes or no? No, yaar. Retinal detachment does not mean detachment of the retina. Retinal detachment means this. Everybody look at my hands if you remember the anatomy of the retina. Detachment of the inner 9 layers, that is the neurosensory retina, from the pigment epithelium. So even though we are saying retinal detachment, the whole retina is not detaching from the choroid. There is kind of, I can say, intraretinal detachment. Yes, the neurosensory retina is detaching from the retinal pigment epithelium and fluid is collecting in the subretinal space. Focus on the anatomy, try to focus. Yes, so if I define retinal detachment, I will say separation of neurosensory retina from retinal pigment epithelium and collection of subretinal fluid. Am I absolutely clear here, everybody? Yes. So the 9 layers, neurosensory retina, the outermost layer, retinal pigment epithelium, subretinal space. What is occurring, everybody? If I draw a diagrammatic representation of it, I can say this is what is occurring. Neurosensory retina is getting detached. Pigment epithelium is at its own place. And there is collection of fluid in subretinal space. Am I absolutely clear? Everybody, very simple definition. Yes? Now, if I ask you investigations, number 1, what should be the investigation of choice for a case of retinal detachment? Again, don't give me big answers. Think about it. Will you be able to see a detached retina by your own eyes? Yes. What will you do? Ophthalmoscopy. Which ophthalmoscopy? Direct or indirect? As simple as that. So the answer will be indirect ophthalmoscopy. You need to be able to visualize the whole retina. When you visualize it, you will see the retina flying in the vitreous cavity. Secondly, can you do OCT? Yes, you can do OCT. In OCT, you will be able to see the detachment of the layers. Number 3, can you do B-scan ultrasonography? Yes, even on a B-scan ultrasonography, you should go back to the part 1 of retina chapter where we have discussed the investigations. In that we have seen a case of B-scan ultrasonography retinal detachment image also. Right guys? So these are the 3 things you can do for the diagnosis of retinal detachment. Right? Now, this actually we already know. This is just a recap of what we know. Now what we should know is what are the types of retinal detachment. So retinal detachment can broadly be divided into 2 types, primary RD or secondary RD. Primary RD is known as rhegmatogenous. Secondary RD can be of 2 types, tractional retinal detachment or exudative retinal detachment. Okay, everybody? So 3 types, rhegmatogenous, tractional and exudative. We will discuss all the 3 types one by one. Let's discuss with the primary first, rhegmatogenous retinal detachment. So, rhegmatogenous RD. Yes? Now, focus on the name, rhegma, rhegma. Rhegma is a Latin word which means break. Break means either a tear or I can say a hole in retina. Once I explain you the pathogenesis, you will realize that rhegmatogenous RD occurs because the retina has a hole or a tear. Retina टूट गया है, इसलिए हो रहा है. And that is why the name is rhegmatogenous, due to a break, rhegma. Yes? Let's understand the pathogenesis here. The pathogenesis starts with syneresis. Syneresis means liquefaction of vitreous. Okay? Due to a lot of causes that I will state in a while, there is liquefaction of vitreous. When there is liquefaction of vitreous, the gel is changing into water, everybody. Yes? This leads to posterior vitreous detachment. What do you mean? PVD, everybody. Very simple. If this is my retina, look at my hand, everybody. The vitreous is a gel and the gel is stuck to the retina. Can I say? Now, when the gel is changing into water, this adhesion will be gone. So there will be posterior vitreous detachment. Vitreous which is posteriorly adherent to the retina will now be detached. Okay, everybody? Leads to posterior vitreous detachment. Done? Some part of vitreous still attached exerts dynamic vitreoretinal traction. I hope you are able to understand this. If not, a very rough diagram. If this is my retina, the vitreous has become detached everywhere, but at some places it is still attached. So at this place, this place, this place, it is still attached. These points are exerting now force on the retina. Am I clear to everybody? They also want to detach. हम आजाद होना चाह रहे हैं. We also want to get detached. Okay? So they are exerting a pull at different places, different directions of force. So vitreoretinal traction. Traction means pull. Am I clear to everybody? Now, because the vitreous is pulling the retina from various points, what will occur, everybody? Retinal break develops. Very simple, everybody. Look at my shirt. If I start to pull my shirt from 2 points, everybody, what will occur? In the center, a break will develop. Because the force is in different directions, a break will develop in the center. Yes, the same thing is occurring in my retina now. Due to dynamic traction, the retina will break. Now, the retina is broken. The vitreous is liquefied. That means there is fluid here. When there is fluid here, and the retina is broken, let's say I will just draw a break for you here. Here the retina got broken. The fluid, everybody, will now enter the retina. When it will enter the retina, it will cross the neurosensory retina and it will go and collect itself in the subretinal space. When the fluid collects in the subretinal space, this fluid will push the retina forward and there will be retinal detachment. Am I crystal clear about this, everybody? Yes. So, fluid enters the break and seeps into subretinal space. Am I absolutely clear? Yes. So, the break has to develop for the fluid to go inside. The only fundamental is how does the break develop? Because of 3 words which you need to remember. Number 1, liquefaction of vitreous, which leads to posterior vitreous detachment. But at certain points, there is dynamic vitreous traction or pull, which leads to development of break. So it's a story, everybody. If you understand the story, you understand why it occurs. If you understand why it occurs, you understand that the break is important, and that is why it is known as regmatogenous. So basically, I can say there are 4 things which are responsible for development. Number 1, syneresis. Number 2, PVD. Number 3, traction. Number 4, break. Done, everybody? No confusion? Now, after we know the pathogenesis, what we should know, everybody, is what are the causes? Okay? Why does this syneresis occur in what cases? Number 1, the most common cause is pathological myopia. Myopia greater than 6 diopters. Okay? The second common cause, everybody, is blunt trauma to the eye. The third cause is cataract surgery, or if I can say so, aphakia. Okay, cataract surgery can make you aphakic if you don't implant an IOL. Fourth important cause is lattice degeneration of retina. Lattice means a fine mesh, everybody. If your degeneration is occurring in the retina, your retina is becoming weaker, atrophied, that can create a break or a hole in the retina. Am I absolutely clear here, everybody? Yes. So these are some of the important causes of a case of regmatogenous RD. Now, after we know the causes, what we need to know is the symptoms. We know that RD has developed. What will be the patient symptom? 3 things the patient will develop. Number 1, the patient will have photopsia. Photopsia means flashes of light. When the vitreous is pulling the retina, everybody, the nerve fibers are getting stretched. The nerve fibers are irritated. When they are irritated, they are firing ectopic neural impulses onto the brain. Whenever the brain will receive an ectopic neural impulse, the brain will perceive a flash of light. Okay, everybody? So even when the patient is sitting in a dark room, the patient will say, it looks as if somebody is flashing light in front of my eyes. Yes? Second, everybody, floaters. Floaters, I hope all of us already know. All of us are able to understand, everybody, floaters. Small, black, flying, dot-like opacities. Okay? Why is this occurring? The vitreous is changing its form. Vitreous is developing some opacities. So let's say vitreous has developed small pockets of opacities. When light will fall onto these opacities, what will occur, everybody? These opacities will cast a shadow onto the retina. Yes? And because now the vitreous is opaque, they will keep on flying. So the patient will say, I see small dots which keep on flying in my visual area. Okay, everybody? So please understand that floaters are due to vitreal opacities. So whenever somebody is complaining of floaters, it means that vitreous is affected. Am I clear to everybody? Now, number 3. Patient complains of curtain falling in front of eye. Yes, retina is like a transparent curtain. Some part of the retina is detached. When the retina is flying, everybody, like this, imagine that a fan is switched on and a curtain in your room is flying, everybody. So that curtain will come in front of the macula, and for momentarily you will feel as if somebody has fallen in front of your eye. Then that will float away. So whenever you will do movement, the retina is also moving. Am I clear to everybody? So that is the classic words. ऐसा लग रहा है आंख के आगे पर्दा गिर गया हो. Am I clear to everybody? Patient complains of curtain falling in front of the eye. These are the 3 classic symptoms, and obviously there will be loss of vision. There should be a no-brainer. The loss of vision will be sudden and it will be painless. I hope I am absolutely clear about this. No confusion. Done, everybody? Now, let's move on to the signs. Number 1, the detached retina is gray, or I can say opaque. Okay, the detached retina is gray or opaque. Because once it becomes detached, it is becoming edematous. Yes, so it is becoming gray and opaque. It is not able to maintain its transparency. See this photograph, everybody. It is very clear that in this area there is attached retina, but all this part of the retina is detached. Yes, no confusion about this, I hope. Let's move back to the signs. Sign number 2. The retinal detachment extends till ora serrata. See, once the fluid has entered the subretinal space, there are no roadblocks in the subretinal space. So the fluid will permeate all throughout the retina, everybody. Yes? So the retinal detachment will keep on extending. It will start from one place, then it will reach up to the anterior limit. So what we are trying to say is, there is no barrier to fluid. So the fluid will accumulate throughout and it can lead to total retinal detachment. Are you getting the point? Number 3, everybody. Detached retina is convex. Meaning, if this is my retina, this part of retina is attached, but let's say this part of retina is detached, so it will appear like this. Okay, everybody? Because the forces have pulled it out, it will be convex. Done? Number 4. Characteristic sign which is called as Schaeffer sign. Tobacco, dust, appearance. Tobacco dust appearance. Due to vitreal changes, everybody, what occurs is, at the anterior face of the vitreous, there are pigmented cells that are deposited. So, okay, I'll again just draw a simple diagram for you guys. Okay, this my retina is detached, let's say. At the anterior face of the vitreous, pigmented cells are deposited, brown color pigmented cells. So when the examiner will look, it will be as if somebody has thrown tobacco on the vitreous surface. That is known as Schaffer's sign. Am I clear to everybody? Now, sign number 5, the patient will have RAPD. Okay. Sign number 6, in long-standing cases. It is a question in itself, everybody. In long-standing cases. Okay, if you have a chronic RD which has occurred, let's say 1 year back or some time back, what are the signs you will be able to see? First of all, there will be retinal atrophy. I hope this is a no-brainer. Secondly, everybody, there will be subretinal demarcation lines. They are also known as high water marks. If greater than 3 months. Okay, demarcation line basically means you will be able to see a complete line between the attached and the detached retina. Okay, everybody, they are also known as high water marks. This name was used by AIMS in 2012 to ask a question. Thirdly, intraretinal cysts will develop if greater than 1 year. So based on the sign seen, you are able to even diagnose the time of retinal detachment occurrence. Am I clear to everybody? So please remember, these 3 are cases, or these 3 are signs of long-standing cases. I'll show you an image, everybody. See this OCT image. When I see this OCT image, what can I see, everybody? First of all, in this area, everybody, I see that the neurosensory retina has been detached. There is subretinal fluid. So it makes a case of RD. When I focus in this part now, everybody, we will be able to see that certain, what have occurred, everybody? Cysts. Intraretinal cysts, everybody. That makes it a case of long-standing rhegmatogenous retinal detachment. Okay, no confusion. And if I show you another photograph, what are we able to see, everybody? A U-shaped tear in retina. Yes, that means it is a candidate for development of rhegmatogenous RD if already not developed. Yes, so everything is clearly visible to us. We can diagnose even the smallest of things. I hope there is no confusion about this. Now, once we know the signs, everybody, what we need to know is the treatment. So first of all, I ask you this word. Is prophylaxis possible for a case of rhegmatogenous RD? Think about the pathogenesis. Once the break occurs, then only rhegmatogenous RD can develop. So if we find a break on examination, can we prevent rhegmatogenous RD? Yes. So we have to try and find a break in the retina in cases we know are causes of rhegmatogenous RD. If we find a break before RRD has developed, we can close the break. Am I clear to everybody? Done? So breaks most commonly seen in superotemporal quadrant. Okay, they can be prophylactically closed by, same answer everywhere, guys, laser photocoagulation. Laser photocoagulation. Am I clear to everybody? No confusion should be there about it. Let's say you were not prophylactically able to treat. Then you would have had to do treatment. In treatment, everybody, we need to see 2 things. The first thing we need to see is whether the retina is mobile or whether the retina has become immobile. if the retina has become immobile, that means something called as PVR must have occurred. PVR, the cinemas? No. Proliferative vitreoretinopathy. Okay? Proliferative vitreoretinopathy must have occurred. Proliferative vitreoretinopathy leads to formation of membranes and scarring. Okay? This scarring makes the retina immobile or taut. If this has occurred, then we say the treatment should be vitrectomy plus subretinal fluid drainage. Am I clear to everybody? Yes, that is the main thing. But if the retina is mobile, then what I can do is I can do tamponading. Tamponade means to put pressure and to join two things. Try to understand this very easy concept, everybody. Let's say this part of my retina has become detached. Okay, everybody? So that means if I just draw it, this is my neurosensory retina, this is my retinal pigment epithelium. This is my vitreous cavity, lens and everything. Okay? I need to push the neurosensory retina back. So I will say internal tamponading. I will put some fluid in here. That fluid will put pressure, neurosensory retina will be pushed back. Or I can put some gas in here. It will push the retina back. Internal tamponading. If internal tamponading is not possible, everybody, what should I do? Now I should push from the external side. So I will put some weight over the sclera. Obviously here will be sclera now. After the retina there will be choroid. And after the choroid there will be sclera. Yes, everybody? So I will put a weight on the sclera. Yes? And that sclera will put pressure. That scleral weight will put pressure and will push the pigment epithelium forward. I need to attach two things. Either I put pressure from one side or I put pressure from the other side. Or my wish. One side, other side. My wish. Am I clear, everybody? Yes? So, let's see. Tamponade. Internal tamponade can be done using gas. In that case, we call it pneumatic retinopexy. Pneumatic means gas, air. Yes? We use sulfur hexafluoride or C3F8. That is basically propane. Either of these two gases have to be used. You can't blow air, everybody. It's not that you will blow it like a balloon. Yes, the air has to have density. You can't do... I hope you understand this. Am I clear to everybody? This is usually done only if superior breaks. Because the gas will rise up. So if there is an inferior break, then the gas will almost always be useless. The second way is silicone oil injected into vitreous cavity. Am I clear, everybody? Oil is heavier than water. It will displace the liquefied vitreous. It will compress. The only problem is silicone oil needs to be removed after around 8 to 12 weeks. See, the air will get absorbed, but oil cannot get absorbed. So even though silicone oil is better actually than pneumatic retinopexy, but you need to remove it. And it has a side effect or a complication, you can say. Hyperoleon. If silicone oil leaks into anterior chamber, it gathers superiorly. Okay? So just like there is hypopion. Hypopion is gathered inferiorly. The oil will go superiorly. Oil floats over water, everybody. Yes. So it will be known as hyperoleon. Okay, everybody. So that is one of the complications that certain times is seen in patients of silicone oil if the oil is not removed. Am I clear to everybody? Done. No confusion about this, everybody. So internal tamponading is either being done using gases, sulfur hexafluoride or C3F8, or using silicone oil. Crystal clear? No confusion? Now, the other way we can do tamponade is external tamponade. In external tamponade, we call it scleral buckling. As already explained to you, a silicone weight is kept over the sclera, then it is buckled. Buckled means it is tied. That scleral weight will push the pigment epithelium anteriorly and will lead to reattachment. Right, guys? In simple words, this is my treatment for rhegmatogenous retinal detachment. No confusion should be there, everybody. Okay? Apart from this, please remember one more word. Linkoff rules. Linkoff rules, they are 3 rules which help us to locate the break in retina. They help us to locate the break in the retina. Not going into what are the rules, but please remember we are trying to locate the break in the retina whenever it is a case of rhegmatogenous RD, and we use a set of rules called as Linkoff rules. Am I clear, everybody? No confusion about this, I hope. Done. That's it about our primary RD, that is rhegmatogenous RD. If you have been able to understand this, the tractional and the exudative are a piece of cake. Right, guys? Tractional RD. Now what we want to discuss is basically the differences from rhegmatogenous RD. So first of all, please remember there is no break. There is no photopsia. Plus there is no floaters. Photopsia and floaters are classically words reserved only for rhegmatogenous RD. Yes? Then comes the question, how does it occur? If there is no break, how does it occur? It occurs due to static vitreoretinal traction. Traction was there in rhegmatogenous also. Traction is in tractional also. The name is tractional. It is telling you it will occur due to traction. But please understand that tractional detachment is due to static traction. There are no forces in different directions. There are no dynamic forces. Due to the causes that we will list, there is a certain point of vitreous which is pulling the retina slowly from one certain place. Yes? So I am just pulling the retina like this from one point, everybody. I am not pulling the retina in different directions. I am pulling the retina from one point in one single direction. Am I clear to everybody? What are the causes? Number 1, the most common cause is diabetic retinopathy. Number 2, it can occur in retinopathy of prematurity. Number 3, it can occur in penetrating trauma. Or number 4, it can occur in sickle cell retinopathy. Sickle cell retinopathy. Okay. Please also remember about sickle cell retinopathy. It presents with Roth spots in the retina. What are Roth spots, everybody? Roth spots are that there will be a hemorrhage with a clear center. Hemorrhage with clear center. Okay, am I absolutely clear about this? No confusion should be there in this. Yes, guys? Now, once we know the causes, let's see what will be the differences in clinical features. Number 1, loss of vision will be gradual and painless. Again, if you understand the pathogenesis, you understand it. Why gradual, everybody? Because the traction is static. It is pulling from one point. So slowly, the retina will keep getting pulled away. First 1%, 2%, then more and more. The more the retina gets pulled from that point, the more the loss of vision will extend. Okay? I've already stated no photopsia and no floaters. Number 3, the retinal detachment does not extend tend till ora serrata. Again, I hope it is very clear. There is no fluid through the break going inside. There is just traction at one point. So the retinal will detach only at one point. It will not be able to be a complete retinal detachment. Okay. Number 4. Very important point, everybody. Detached retina is concave. It will be detached, but it will be concave when you look at it. It will not be convex. Am I clear? I hope I am, everybody. Yes, these are certain differences, everybody. Nothing more to discuss. Please do remember these points about tractional retinal detachment. The treatment is the same, everybody. You have to do vitrectomy to cut the traction, and then you have to do the tamponading. Done? Now, let's move on to the last type of RD, that is exudative RD. Now, if you ask me, sir, why does it occur? So I will say it occurs due to various local and systemic causes which lead to exudation. Am I clear to everybody? Exudative is occurring due to exudation. So diseases like malignant hypertension, which can cause exudation, everybody, they will cause exudation of fluid into the subretinal space, everybody, and it will lead to exudative RD. There is no local cause. There is no vitreal cause. There is no retinal cause. Am I clear to everybody? So if you ask me then, sir, what are the diseases? Number 1, most common cause is choroidal melanoma. The choroid is going. So the choroidal blood vessels are causing exudation. Yes. The second important cause is toxemia of pregnancy. Toxemia of pregnancy, HELLP syndrome. Yes. Number 3, everybody. Coats disease. We have mentioned just a while back, idiopathic retinal telangiectasia, telangiectatic vessels causing exudation. Number 4, VKH syndrome. And number 5, important cause, CSR, central serous retinopathy. I hope you remember there is collection of fluid in the subretinal space due to exudation from the choroidal blood vessels. Am I clear? Now, clinical features. Number 1, the loss of vision is again sudden and painless, convex, detached retina, just like our rhegmatogenous RD. Number 3, everybody, there will be shifting fluid. This is the hallmark of exudative retinal detachment. What do we mean by shifting fluid, everybody? Again, think about an exudative process called ascites. How do we diagnose ascites, everybody? Because of shifting fluid, everybody. Yes or no? We get the tamponade, everybody. Yes. We ask the patient to lie down on one side, then lie down on the other side, because the fluid will shift. We will get the air tamponading effect. Yes or no? When we do the palpation over it. Yes, everybody. Am I clear about this? The same thing will occur in my retina. One, I ask the patient to hold his or her head like this. All the fluid will collect in this part. This portion of the retina will detach. When the patient changes the head posture to this side, the fluid will collect in this part. If the patient is lying down, the central part of the retina will become detached. So the fluid, subretinal fluid, obviously we are talking about, moves with the movement of the head, and thus the position of the retinal detachment keeps on changing throughout. Yes, the treatment, there has to be no local treatment, everybody. The treatment has to be systemic. You have to treat the cause. So you don't have to do any tamponading, any vitrectomy or anything like that. Am I clear to everybody? So these are our 2 types of secondary retinal detachments, tractional and exudative. The main thing we want to learn and understand is rhegmatogenous, and then just learn some of certain differences. Right, guys? Done? I hope we are absolutely clear about retinal detachment. Very small, very simple, and very interesting pathogenesis. And that's the last disease that we have covered as part of retina. I hope you have been able to gather retina around your head. We started with the anatomy, then we did the investigations, then a tumor retinoblastoma, macular disorders. All the macular disorders will have the same test, will have the same symptom. We just need to be able to differentiate based on certain tests like CSR, CME based on FFA. Then we did our fundus dystrophies, rod cell or cone cell problem, as simple as that. Vascular diseases, all of them the same, pathogenesis and treatment. And then lastly, retinal detachment. I know it seems like a large chapter, but I hope you have been able to go through it. You have been able to learn and importantly comprehend the common concepts from each, and thus you will be able to be confident about all the questions that come on retina. Retina is frequently asked in AIMS exam, everybody. Also asked in NEET, but not as frequently. So you will find the majority of paper of AIMS somewhere related to retina. But in NEET, you will usually get 2 questions or maybe even 3 sometimes.